Welcome to this lecture. I am here to guide you through a high-yield visual guide to antihypertensive pharmacology brought to you by CleanMed-KE, where we aim to make clinical medicine and surgery clear, structured, and clinical. Our goal today is to demystify the complex mechanisms of blood pressure regulation and the pharmacological interventions we use to manage hypertension in a clinical setting. Physiologically, blood pressure is the product of cardiac output and total peripheral resistance. Notice the icons for heart rate represented by a pulsing heart, stroke volume shown as blood ejected from the heart, and TPR depicted as a narrowed blood vessel. Every antihypertensive drug we discuss today works by pulling one or more of these physiological levers. For instance, if we decrease the heart rate or stroke volume, we lower the cardiac output. If we dilate the peripheral vasculature, we lower the resistance. Either action results in a decrease in systemic blood pressure. Before we can inhibit it, we must understand the renin-angiotensin-aldosterone system. When the kidneys detect low sodium or low blood pressure, they release renin. Simultaneously, the liver produces angiotensinogen. Renin cleaves angiotensinogen into angiotensin I. As blood passes through the pulmonary circulation, the angiotensin-converting enzyme, ACE, produced by the lungs, converts it into the potent angiotensin II clinical outcomes. Angiotensin II is the pathology driver here. It causes direct vasoconstriction, increasing TPR, triggers thirst and ADH, increasing blood volume, and stimulates aldosterone release from the adrenal cortex to retain sodium and water. On the left, a large red X indicates the blockade of the conversion process. The mechanism, ACE inhibitors identified by the suffix pril, e.g., captopril, enalapril, block the enzyme responsible for creating angiotensin D-sen2. This leads to a systemic depletion of angiotensin II, resulting in vasodilation and natriuresis, the excretion of sodium and water. Clinical pearl. These are miraculous for renal protection, particularly in diabetic nephropathy and scleroderma renal crisis, because they reduce the efferent arteriolar resistance in the kidney. Why do patients on ACE inhibitors often develop a cough? Normally, the ACE enzyme also breaks down bradykinin into inactive fragments. When we inhibit ACE with a pril, bradykinin accumulates. Adverse effects. The visual shows bradykinin leaking into three pathways. Dry cough, the most common reason for discontinuation, angioedema, a life-threatening rapid swelling of the face and airway, hyperkalemia. Because we have suppressed aldosterone, the kidney no longer exchanges potassium for sodium, leading to elevated serum potassium levels. Note the contrast here. The ACE enzyme is working normally, represented by the scissors, but the AT1 receptor is blocked by a red X. The mechanism, ARBs identified by the suffix sartanin, e.g., losartan, do not stop the production of angiotensin II, they simply prevent it from binding to its primary receptor. Key difference. Because ACE is not inhibited, bradykinin is degraded normally. Therefore, the dry cough is absent, and the risk of angioedema is extremely rare, making these a preferred alternative for patients who cannot tolerate ACE inhibitors. Analysis. This table highlights the clinical logic of choice. While both classes target the ARBs and cause hyperkalemia, they differ in their side effect profiles. Indications, contraindications. Both are strictly contraindicated in pregnancy due to their teratogenic effects on fetal renal development. However, the ARBs offer a very low risk for cough and angioedema compared to the high risk seen with ACE inhibitors. We see a diagram of the nephron, the functional unit of the kidney, with three numbered markers. The golden rule is shown. Where sodium goes, water follows. Diuretics work by blocking sodium reabsorption at specific points in the nephron, forcing sodium and thus water into the urine, directly lowering blood volume. Loop diuretics, e.g., furosemide, represented by a 100 libid weight because they are the most powerful. They are used for severe volume overload and chronic kidney disease, but can cause severe hypokalemia. Thiazides, e.g., HCTZ, represented by a dumbbell, are mild diuretics that also induce vasodilation. They are first line for mild essential hypertension, but can trigger gout by increasing uric acid or cause hypercalcemia. Potassium-sparing like spironolactone, represented by a feather because they are weak diuretics. They block aldosterone and are used to prevent potassium loss, but can cause gynecomastia and metabolic acidosis. Red shields are shown blocking beta-1 receptors on the SA node, pacemaker, and the ventricular wall, cardiomyocytes. The mechanism: beta blockers, OLol, like metoprolol, blocks sympathetic adrenaline from hitting these receptors. Net effect: this decreases heart rate and contractility, lowering cardiac output. Clinical warning: non-selective beta blockers must be avoided in asthma, as they can cause life-threatening bronchoconstriction by blocking beta-2 receptors in the lungs. Calcium channel blockers, CCBs, are split into two distinct clinical categories: dihydropyridines, DHP, e.g., amlodipine. These target vascular L-type channels, causing powerful vasodilation. Common side effects include peripheral edema and reflex tachycardia. Non-dihydropyridines, e.g., verapamil. These target cardiac T-type pacemaker channels, lowering heart rate and contractility. Critical rule: non-DHPs are strictly contraindicated in systolic heart failure because they weaken an already failing pump. Alpha and central sympatholytics. Central agents: clonidine, methyl-dopa. These stimulate alpha-2 receptors in the brain to cut off sympathetic signals before they leave the CNS. Methyl-dopa is the drug of choice for hypertension in pregnancy. Alpha-1. Blockers, doxazosine. These block vasoconstriction directly at the blood vessel. Clinical pearl: they are famous for causing severe orthostatic hypotension, dizziness when standing quickly. Specialized vasodilators, bosentan, an endothelin-1 antagonist used specifically for pulmonary hypertension. Nitrates, direct IV vasodilators that flood the system with nitric oxide, used for hypertensive emergencies. Minoxidil opens potassium channels to relax muscle. A unique side effect is hypertrichosis, hair growth, which is why it is now used topically for baldness. Heart failure, breaking down the cycle, the pathophysiology. When the heart weakens, the body panics and activates RAS and the sympathetic system. This paradoxically overworks and scars the heart, leading to further damage. The process: we use ACE inhibitors and beta blockers as disease modifiers to halt this toxic structural remodeling and extend life. Symptom managers like digoxin may help the patient feel better, but do not stop the underlying remodeling. Finally, we look at the clinical matchmaker. For diabetic nephropathy, use ACE inhibitors ARB for kidney protection. In systolic heart failure, use ACE inhibitors and beta blockers, but avoid non-DHP CCBs. In pregnancy, avoid ACE inhibitors, sham ARBs due to teratogenicity, and use methyl-dopa. Asthmatics should avoid non-selective beta blockers, and patients with gout should avoid thiazides. Effective clinical decision-making relies on matching the right drug mechanism to the specific patient profile while avoiding clear contraindications. Thank you for joining this lecture. If you found this high-yield guide helpful, please like, share, and subscribe to Clean Med KE for more simplified medical education. Let's keep making medicine clear, structured, and clinical.